entertainment. So we like to look at TRUS-based prostate HDR for both the beginner and advanced users. And I would like to introduce my co-presenters for the evening, Dr. Dan Krauss, who is head of brachytherapy at William Beaumont, associate professor at Oakland University School of Medicine. Also, Mahta McKee is a physicist at Wake Forest School of Medicine, where she's also an associate professor. And as mentioned, my name is Gerard Morton from Toronto. The objectives of the next hour or so will be to enable the attendees to design a process for TRUS-based HDR brachytherapy at their own institutions, know how to prescribe and optimize a prostate HDR plan, and incorporate other imaging modalities, in particular MRI, into the TRUS-based process. So without further ado, I would like to invite Dr. Krauss to take over and share his screen. So during the Dan's presentation, please ask questions as they come to mind in the chat function. I will be monitoring these during Dan's talk, and on completion, we will have 5 minutes for questions. So just the format of this evening, each of the presenters will speak for 15 minutes with 5 minutes afterwards for questions and discussion, and hopefully we will have a little bit of time at the end for a more general discussion. Over to you, Dan. Thank you.
So everyone can see my my title slide
Yes.
up here, correct? Okay. So obviously, I can't hit on every detail of ultrasound-based prostate HDR in 15 minutes. Going to try to hit the high points and sort of emphasize, some of the things that we do here at Beaumont, try to contrast that a little bit with some of the other practices that are out there. You'll hear, some of Gerard's techniques as we get further along. But I'm going to be talking basically about standard whole gland prostate HDR brachytherapy and how we optimize that with ultrasound-based planning. All right, so just before we get into the details here, with any procedure in medicine, patient selection is critical. You're always going to look at general clinical and medical factors, the age of the patient, what comorbidities do they have, or the anesthesia risks associated with going through brachytherapy worth taking for this patient. Certainly baseline urinary function in an untreated patient. I'm usually pretty comfortable looking at urinary function independently. Comfortable doing an implant on a patient with an AUA symptom score less than 15. If they're on alpha blocker usage and have a score of 10 to 12 or less, I'm usually pretty comfortable with those patients. The anatomic and technical considerations you're going to be looking at are the gland volume. I don't get concerned about gland independently until we get up around 70 cc's. Of course, as the gland size gets bigger, you're more likely to, run into other anatomic challenges, rectal spacing, median lobes, pelvic arch interference. The urethral position, you want to make sure that the urethra follows a course that you can avoid when you're placing your needles, and also that isn't going to be a dosimetric hindrance when you're trying to dose the entire gland. You always want to emphasize the width of the pubic arch, make sure that's not going to interfere with your needle placement as you're going. The other patient selection factor that I wanted to talk about is whether or not you're going to do monotherapy or combination therapy for these patients. Monotherapy is really not considered standard therapy for NCCN high risk. It's a very, it's an area that I'm very, very interested in, especially as we continue to use MRI more and more. If you have organ confined disease and favorable high risk features, is this something that we could get away with? But by limiting external beam, you spare, certainly the majority of the integral dose that boost patients are going to be exposed to. You certainly limit rectal toxicity. We just reviewed our series published in the Green Journal at Beaumont, where monotherapy patients had chronic grade greater than or equal to 2 rectal toxicity rates of really about 2 to 3%. So, you really limit one of the major toxicity profiles of radiation for prostate cancer when you're able to do HDR as monotherapy. So it'd be nice to better identify patients who are candidates. It has been done before. There's a series out of Japan that reported favorable long-term control rates, but I would not recommend this as standard of care in this country. When you're looking at this, obviously for the intermediate risk patients, you're going to look at the number of intermediate risk features that the patient harbors. And really, it comes down to a comfort level. I will frequently lean pretty heavily on MRIs for intermediate risk patients, that if it's focal organ confined disease in the intermediate risk population, and you're confident in the MRI interpretation, I'm usually very comfortable with that. Of course, the other issue is nodal therapy, which you can't address with brachy. So let's start looking at the technical aspects. Patient setup, you've got the patient supine, legs and stirrups in the dorsal lithotomy position. We'll usually elevate the stirrups to an angle of about 50 to 55 degrees. Place the catheter. You can see here our basic setup. You guys can see my mouse pointer, I hope, but you'll place the ultrasound probe with the template flush against the perineum. We've got our Mayo stand over here, really with just about everything we will need for the implant. One thing I will say, when you're placing the ultrasound probe, pelvic arch interference usually is not an issue with smaller prostates. And while you definitely want the ultrasound probe as parallel as possible to the long axis of the prostate, one technique you can use if there is arch interference, you can increase the hip flexion, place downward pressure and upward tilt on the probe. It brings the needle placement axis more in parallel with the arch and can help decrease arch interference. But you just have to pay very close attention to the needle tracks because they won't be following the prostate in parallel. We use, of course, because it's Beaumont, we use the Electa Martinez interstitial template, which you can see here. This largely mimics the custom in-house equipment that we used here for many, many years. Here's a close-up of our Mayo stand with really all of the equipment that we need. You can see here the wrench that we use to tighten the collets. This little basket here holds all of the collets that are placed in the template positions. Our needles are here. We keep one mosquito clamp, which you need if you want to ever, for whatever reason, remove a collet from the template. You can't see it too well here, but we'll keep a hook to help deflect needles for optimal positioning, a ruler, and if the patient's skin is thick, sometimes you'll want to break the skin with a sharp metal needle. So when you're placing your needles, here's just the typical wide axial slice of a prostate. I'm going to sort of walk you through. I tend to use more needles, I would say, than the average practitioner. I like having the options. I tend to do implants that are a little more on the homogeneous side. When I'm placing my needles, I always start with the anterior 2 needles. I try to keep these as close together as I can on either side of the urethra. So you track the urethra from base to apex, make sure your needles aren't going through. I'll generally work around the periphery of the gland, placing my needles so as to minimize any imaging artifact. You can see what you're doing better if you place your anterior and lateral needles first. Then I'll place my central needles, anterior, posterior, and then my posterior row here. In addition to this, a couple of points. I generally will crowd the needles a bit in the posterior row, especially if there's poor rectal spacing. That just gives you a little bit more flexibility with your dose painting. And the other thing that I will do that we didn't used to, I will place this central needle. Sometimes I'll do 2 on either side of the urethra, but a central needle is sort of directly behind the urethra here for apex coverage, because your apex slice is not going to look like this. Your apex slice is going to look something like this. And if you don't have that central needle in there, it's just really hard, especially if you have a patient with apical disease, to cover that. So once your needles are placed, you do your image acquisition, remove the metal stylets from the plastic catheters as they can flex or bend. While this can potentially make them a little bit more difficult to identify, you can still see them very clearly on the ultrasound, and it will yield more accurate dosimetry because this is what you're treating. Before we acquire, we will always inject a mixture of gel, normal saline, and air bubbles into the catheter for clear urethral demarcation. And we'll do this immediately prior to acquisition, although the bubbles last a while. If you have to reacquire for any reason, 5-10 minutes later, the bubbles should still be good. We acquire images 10 millimeters deep to the needle tips to 10 millimeters beyond the prostate apex, and a continuous acquisition of 1 millimeter slice thickness. When you're verifying your needle positions, you got to look in multiple planes. You can get in the ballpark on your axial images, but then you'll want to verify the needle tracks in the sagittal and coronal images as well. We still do cystoscopies at Beaumont. You don't need to do this. I like having it. I have a great relationship with our urologists here. It's, you know, we get our needles and we have them come down, perform a cystoscopy. We can help verify the length to ensure that we're not under-treating the length of the prostate. You can verify that you're not violating the urethra or bladder mucosa. You know, remember what you're seeing as, quote, urethra is not really the urethra. You're seeing the catheter on the ultrasound. So sometimes you think you're nowhere near the urethra, and then you do a cysto and you get a little surprise when you look in there. You can also retroflex the scope, verify that the needles are advanced to the base by visualization of bladder mucosa tenting when you put pressure on the needles. So needle identification on ultrasound is definitely more challenging than on CT. It's subject to imaging artifact in the form of shadowing. If you truly cannot see the needles, you can flip back and forth from live images. This is a technique that we find very useful. If you really can't see them because a needle is hiding behind another one, you can back a needle up a bit, identify the needle that's anterior to it, and identify it more confidently. So if you take a look at this image in the upper left here, you can see, if you compare it to where we've digitized our needle on the bottom, this L16 needle in the anterolateral position on the patient's left, you really can't see that needle very well. So what we did, we would go to live image, we would back out either this number 9 or number 13 needle. You back it out far enough and the needle pops into view, track it under live imaging until you're reasonably confident of the course that it's following. So this will happen from time to time, especially if you're like me and you put a lot of needles in for these procedures. And you can see that this needle configuration very closely mimicking what I showed you a moment ago for sort of an ideal placement. I do recommend on the physics end, active needle tracking throughout the procedure. This will make the digitization process much quicker and easier. You can see here a representation in the coronal plane, and down here looking on the sagittal, you can see a needle very clearly advanced right up to the Foley balloon, and one of our posterior needles advanced a little bit deeper to treat the seminal vesicle. We'll touch on this a little bit more in a moment. Contouring on ultrasound. So the gland capsule is clearly, as you can see the prostate on ultrasound without needles in, it can get a little fuzzy once you have all these needles and they're casting shadows everywhere. I would still contend that identification of the gland capsule is much more accurate than trying to do so on a CAT scan where you really can't see it at all, but probably not as good as on an MRI. So a couple things that can really help you is, one is remembering where you put your lateral needles relative to the gland capsule. That if you were putting them right on the capsule, a few millimeters inside the capsule, at various positions as you go cranial to caudal throughout the prostate. But also it's really important that you remember what you're treating. So if you're really not seeing it, you're not confident with identifying the capsule, you know, when in doubt, over contour aggressive disease and under contour indolent disease or areas of the prostate that are uninvolved. Obviously, all things equal, you want to contour the prostate, but that is a challenge you're likely to be faced with. So remembering the clinical disease picture is important. We define our urethra as, at Beaumont, we use a 6 millimeter diameter circle around the catheter, or that bubble mixture that you'll see. I'll show that to you in a moment. But those urethral bubbles can really be key, especially if you're placing needles behind the Foley. That's a terrible feeling when you cannot identify the urethra and you're, sort of guessing, but really not an issue if you use this sort of bubble technique. You can see it very, very easily. The rectal contour should ideally include the outer rind of rectal mucosa. I write do as I say, not as I do, because if you look down here at the bottom, at Beaumont, we've always sort of used this surrogate triangle to represent our rectum. We rationalize that by virtue of the fact that we've always we back the probe out before we treat to minimize any compression. Probably most people leave it in for more accurate dosimetry. This is just sort of the way we've always done it. But the ideal rectal contour is what you see outlined here in red. Just so you can visualize the rectal mucosa, and I would just contour a semicircle, and you're looking at absolute dose volume parameters rather than relative, so it doesn't matter too much. It's also important, we found in the optimization process, we'll add this ring structure, this blue ring structure. If you don't put that in there to sort of trick the optimization software to heat up these internal dwells, a lot of times it won't do it because it can push all of the dose in from these outer needles, and they're further from the urethra. You can see here this this white echo in the center. That's what you see with the bubbles. So you can see it's very unambiguous. Once you've done your contouring, you select your dwell positions. You can preset this however you want. We have our settings that it will automatically activate any dwell position within 5 millimeters of what you contour as target. However, still go through and look manually. Sometimes you'll have dwell positions that are activated immediately adjacent to the urethra. Just turn those off. You won't need them, and it'll wreck your urethral dosimetry. But also, as you look here on the 3-dimensional rendering, you can see these dwell positions posteriorly likely aren't going to do much for us. I usually will turn off all dwell positions that are beyond the apex, because you can usually cover the apex adequately without those, and those will just serve to increase your urethral dose. So after you inactivate those, you get a dwell plan that looks more like this. Personally, I am very comfortable with dwell positions outside of the prostate. You just have to look at them all and determine the risk-benefit ratio, how badly you need coverage, and is it increasing dose to critical structures. So dose prescriptions, I'm not going to spend a lot of time on this. This is just sort of textbook stuff. Monotherapy standard dose 1350 times 2. This is what we do at Beaumont. We typically do it in 2 separate implants separated by 2 weeks. It can be done in a single implant. On the rare occasion that I actually do that, I do make the patient stay overnight. I don't like doing 1350 twice, 6 hours apart. It just makes me a little uncomfortable, but it could be done. We've in fact published on that quite a while ago. It seems to be safe to do. 950 times 4 is sort of the classic monotherapy dose, what we always used to use until about 15 years ago when 2 fractions became our standard. Nothing wrong with this. It's just a little bit more logistically challenging to give. And obviously, if you've been paying attention to the updates on single fraction protocols, don't do them off protocol. Local recurrence rates are much higher. So unless you're bringing something new or novel to the single fraction game that you think should make it work better, I just stay away. For HDR boost, 15 gray times 1 is definitely the most commonly used regimen. We still use 1050 times 2. Anything in the range of 950 to 1050 times 2 is reasonable as well. I'm comfortable with either of these. When you're planning, standard planning recommendations, you can see on the left, V100, you should be able to get over 95% coverage pretty much uniformly, but at least 90%. V125, there's a range for these depending on operator dependence a bit, but somewhere between 50 and 65% generally for the V125. V150, similar, usually between 20 and 35%. Urethra V125 less than 1 cc and a max dose under 150% of the prescription, and 1 cc of rectum should be the maximum, getting 75% of the dose. I've found, I very rarely would I ever accept an implant under 97%. And if you spend enough time on your plan and you really go through things, 99% is frequently achievable. My implants, largely because I use more needles, tend to be a little bit more homogeneous. My V125 tends to run between 50 and 60, and my 150 a little bit on the lower end of that range. I'm usually between 18 and 25%. And if you really look and pay attention to the urethral dosimetry, you can keep all of your hotspots off the urethra. I mean, this is the beauty of this planning software. Typically, my implants have a urethral V110 of 0%. And our rectal constraints are similar to standard. So here's an isodose representation of a typical implant that we do. Obviously, you've got good coverage. Your 100% isodose line is in red. You've got the 3D dose cloud over here. But if you pay attention to the 110% isodose line, you can see your urethra here centrally on the coronal, and just how much control you really have over this. You can, I mean, run that line right up to it, yet entirely keep it off. Here's the widest axial dimension. You can see what a very typical dose distribution looks like. In hindsight, I probably could have cooled down a couple of these posterior dwells and kept more dose off the rectum. But again, when you look at the sagittal, again, if you pay attention to that 110% isodose line, you can just see, you know, the exquisite control that you really have over this. It sometimes takes an extra 10 minutes or so of fiddling with the optimization software, but you can just get beautiful plans with this. Here's the DVH. This is in the Electa on Centra program. It's got this sort of nice stoplight feature where you can put in your own treatment planning goals and constraints, and if you meet them, they show up green. If you're in sort of your like deviation acceptable range, they're yellow, and if you exceed what you specify, they come up red. I'll say a couple things about covering extraprostatic disease with brachytherapy. We're finding this more and more now that more and more patients are getting MRIs prior to treatment. As I mentioned before, there is limited data suggesting that monotherapy may be adequate for selected patients with high-risk disease. Does this suggest that, you know, extraprostatic disease is adequately covered with HDR brachytherapy? I think it needs to be studied, but my feeling is, especially if it's relatively a limited extent of extraprostatic disease, you can certainly cover it with brachy, but obviously it doesn't get you around the issue if the disease is more advanced of treating the lymph nodes. So you may have to add external beam for that. You always have to consider the location of the extraprostatic extension and the extent of the extraprostatic extension. If you just see capsular abutment where you get a radiology report saying there's suspicion for it, I'm very comfortable doing monotherapy if that's a patient with Gleason 7 disease. If it's gross and you see a large mass just, you know, blasting right through the capsule, I'll usually do combination therapy. So when you're here, so again, here's a typical looking implant, you know, very easy to put needles in this area if this is where you're seeing the extraprostatic disease on the MRI. If you're seeing it more anterior and lateral, you're not going to get your needles up in this area, not very far outside of the gland in most patients anyways, because the bone is going to be in your way. So again, you look on the MRI in the lower right-hand corner, extraprostatic disease in that area, green circle, you can usually cover it. This area, not so much. We'll wrap up here talking a little bit about seminal vesicle coverage. I do this very frequently now. The rationale being, number one, we very rarely treat low-risk disease anymore. When I started doing this procedure 20 years ago, we were treating tons of Gleason 6 prostate cancer. We almost never do it now. And in intermediate risk disease, you treat the seminal vesicles. So if you do it with external beam, if you treat the proximal 1 centimeter of seminal vesicles, why not do it with brachy? And it's usually pretty easy to do. Considerations when you're doing it, what's the risk of involvement? If you have high volume aggressive disease at the base, yeah, I'm going to do it. If you have low volume non-aggressive disease that's only at the apex, you know, it may not be worth it. There's also the anatomic considerations. Does the position, the axis of your posterior needles yield favorable dose coverage? And is it going to increase your dose to your bladder or your rectum? So here's looking at an axial slice through the seminal vesicles. You can see we have 1, 2, 3, 4 needles advanced nicely into the seminal vesicles. You can see how we would typically contour this to include the proximal 1 centimeter of seminal vesicle tissue, just like you would in an external beam. I'm not chasing this more distal seminal vesicle tissue. But if you put your posterior needles in and they come out here, 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 and here, where they're sort of anterior. It just sort of depends on how the seminal vesicles rest relative to the posterior aspect of the prostate. That's going to give you at least as much dose, if not more dose, into your bladder than it is into your seminal vesicles. If your needles come out here, 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 and here, instead of in the gland, that's going to do the same thing to your rectum. So you have to apply your clinical judgment to this. So if it's a high risk, you might be more willing to accept suboptimal anatomy or needle placement. If it's low risk, only accept optimal anatomy or placement of your needles. So this is what it looks like when you load those needles up with an HDR source. Generally speaking, is very amenable to a nice single plane implant, and you can cover them very, very well. This would be really an example of perfect anatomy, where you can see the Foley balloon up here, the rectum back here. They're sort of equally spaced between the two and not substantially increasing the dose. So a couple of pearls specific to ultrasound-based planning here. I would highly recommend tracking and digitizing the needles in real time as you're putting them in. That can speed up the process later on. As we said, remove the stylets prior to image acquisition for optimal planning accuracy. Use that gel, saline, and air mixture injected into the catheter before you acquire your images so you can accurately delineate the urethra. Use multiplane imaging to verify the correct needle depth and reconstruct them accurately. Always consider the clinical factors such as disease extent and aggressiveness when contouring ambiguities arise, and take advantage of the amazing optimization tools that the planning systems offer. So that's it. I'm done.
Thank you, Dan. There have been a lot of questions, but I'm going to suggest we hold these because a lot of them actually are going to be answered in the subsequent presentations. So just in the interest of time and moving on, what I might suggest is we hold some questions. I've been answering some of them as we go in the chat, but a lot of the more will come. It's great that some of the points that are going to be brought up are already being anticipated by the audience. So thank you. So maybe hold questions maybe for now. Mahta, maybe I'll let you share your screen and
Sure.
Take over. Thank you.
Hi, everybody. Thank you for joining us today. I am going to share my screen now, and let's start from the beginning. All right. Thank you, Gerald. And after that wonderful talk that Dan gave, it's going to be hard for me to top that. So just bear with me, please. What I'm going to concentrate on is mainly going to be physics related and the ABCs of what you need to look for and when you're doing ultrasound prostate base. Before we start with the ultrasound, let's have a workflow comparison of what CT-based prostate workflow is versus an ultrasound base. So in a CT base, you've got the catheter placement. Now that could be done in the main OR or if you have a brachy suite. Depending on where you are going to be putting the catheter placements, the patient needs to stay in a PACU or a holding area before they could be moved to a CT simulation. After your CT is completed, you've got two ways that you could do your contours. You will either have your contours basically sent to a third party like MIM and have the physician contour there while the physicist is basically doing your catheter reconstruction, or you can send everything to your Oncentra or treatment planning system, do your contouring and then reconstruction and followed by planning. At the end of the planning, the physician would review it. Physics needs to do QAs, and that's QA of the plan, and prior to that, QA of the machine, of course. And then it's your delivery. The CT-based workflow can go anywhere between 4 to 6 hours to deliver one first fraction, depending on, and I say 4 to 6, that includes the experience that you have as a physics and physician team, as well as whether you have a brachy suite within your department, it's a CT simulation in your department, and so on and so forth. Now, based on ultrasound workflow, what you see is basically an interchangeable process that you're looking at. You've got the catheter placement. Ideally, with the ultrasound base, you would hope that you have a brachy suite in your department where the patient does not have to move. You can basically have a one-stop shopping. So you have your catheter placement while you've got the imaging taken, as well as contouring, planning, needle insertion, reconstruction, and finally delivery. Keeping in mind that during this entire process before delivery, you're able to manipulate, as you'll see further on in the talk, you'll be able to manipulate whether it's your catheter reconstruction, whether it is your contouring, all of those can be done as you're going along and updated. With respect to ultrasound scanning, there are two different methods that you can actually scan. One, which is the most common one, is using the transverse view, where the probe goes superior to inferior. The slices, they're going to be 1 millimeter slices captured in increments of 1 millimeter. And then once the entire data is collected, you'll have a 3D view of your 3D envelope of your images. And then finally, once that is done, then you're able to basically contour, do all your structures, needle reconstruction, needle insertion, and finally planning. The second method with the ultrasound is that you can use your sagittal view and basically whether with a motor or hand, take sagittal slices. And again, once all that data is gathered, it would combine and create your 3D view. So either way, there is no right way or wrong way. A lot of people prefer to do the sagittal, but if you're using the sagittal image, make sure that you also look at your transverse and vice versa. This is the end result. So what you want to do after your imaging is to make sure that you have got that volume that you're looking for completely intact and in your field of view. Now, since this is an ultrasound planning and ultrasound-based treatment, what you need to make sure is that your QA process is in place. So the treatment planning system, commissioning, and quality assurance need to be something that you regularly make sure that you are up to date with that. Of course, as soon as you get your machine, you will be doing a complete commissioning and acceptance testing, but you need to make sure that that is continued on an annual basis. Then you have your HDR QA, which is on the same day of treatment, you have to do these machine QAs to make sure that everything is working fine, your connectivity is correct, your door interlocks are correct, everything that is related to your HDR unit is working. And since this is mainly an ultrasound, so your reconstruction, your contours, everything is based on the ultrasound, you need to make sure that you have a very comprehensive ultrasound QA. Based on TG 128, if you read that, there are ultrasound QAs that you have to make sure you do on an annual basis. Okay, at our facility, for example, we have actually the diagnostic people come down and do our annual QA for our ultrasound to make sure that we are not missing anything. With respect to contouring, this can be done on your transverse slices every 5 millimeter or on any of the other 3 planes. So you've got great contouring tools. What I'm talking about here is mainly the Oncentra system, but the similar systems in Varian would be the same. They've got great tools out there that you are able to basically, with 3 slices, whether it is apex, central, and base, you could basically make an envelope and get your target volume, your PTV volume. And this is how you're going to go about and do it. Another method of it is to use the Pearl contouring tool, which is basically you're able to manipulate the diameter of a ring and reconstruct your urethra based on that. The minimum requirement that you would need for contouring is your PTV prostate, your urethra, and bladder, and some people would also basically draw rectum as well. So for our department, the 4 of them are always contoured: prostate, urethra, rectum, and bladder. As you will see further on in the presentation, there are multiple methods of optimization. Depending on what kind of optimization you're using, catheter insertion can be different, or catheter identification can be different. If you're using Hippo, and I'll get to that in a minute, you can have pre-selected needle locations that would actually come up on your screen once you run the program. And based on that, you're able to say where your virtual needles are. As you can see, I have a V in front of those numbers, and then the two yellow that you're seeing is the live needles. So as soon as you select your virtual needles after you've allocated where locations are, and you insert your actual needle through, you're able to guide your virtual to overlap with the real needle. And at that point, you would know your virtual would transfer into the live needle that you have there. As you can see here, for example, on the image on the right-hand side, I've got the actual needle in there, but the green at the bottom needs to be lifted up in order to overlap. And on the left, you will see my virtual is now going right on top of the actual needle. And this is how it would look once it's on top of it. Then V4 would turn to be a L4, meaning it's a live needle number 4. Now, once, as Dr. Krauss mentioned earlier, once you have these needles in place and it goes to the end, you need to make sure the stylets are out. And that is your final reconstruction, because when you have, these are all plastic, majority of the ones that is commonly used are plastic needles. So when the needles are put in with a obturator, the obturator is metal. So it's more or less going in a straight path. As soon as you take the obturators out, you will have some curve introduced into your needles. So you need to make sure you do a final reconstruction of these needles once the obturators are out. Secondly, again, as it was mentioned earlier, it is a little more challenging with ultrasound based to make sure you know where the tip of the needle is. This is very important because first dwell position in any reconstruction, in any HDR process is very important. So you need to identify where that first dwell position is and how to define that tip. The software does have tools, and it's referred to as free length, using the free length measurement of the needle. So it will guide you to make measurements from the outside to know how far you need to go inside your actual volume. Optimization, at least with there are multiple ways of optimization. There's no right way or wrong way to do volumetric optimization. Two of the very common optimization softwares that are available for the electro units are IPSA and HIPPO. IPSA stands for Inverse Planning Simulated Annealing. What it does is that the user would define where you want the catheters to be put in. Once the catheters are put in and you run IPSA based on the constraints you have given it, IPSA is able to put in the dwell positions, normalize, optimize, and prescribe at the same time, okay? However, keeping in mind that IPSA is very completely actually contour driven. So if your contours are incorrect, your activations are going to be incorrect. You need to make sure that the activation is relative to where you want it to be. That is why for IPSA cases, if you want to activate outside of the PTB, you usually give a margin. You can have a margin of 5 millimeter, for example, 10 millimeter, however you define as a user to say activate outside of that volume. Now, HIPPO, which is the most common optimization that is used for on-centra prostate in particular, stands for, it's a hybrid inverse planning and optimization. So it does it has two functionalities. It does the inverse planning and it does the inverse optimization. The user is able to actually predefine how many needles they want to put in, and the system, the HIPPO, is able to optimize based on the constraints and the number of needles and give you a virtual plan of how it's going to look like. At any point, the user is able to stop HIPPO, manipulate, add needles, take needles out, and then regenerate that, calculate that. This is, my apologies for that. This is basically a summary of various prescriptions and various centers that are using prostate HDR with ultrasound, and basically giving you a, or non-ultrasound base, and giving you the parameters, the constraints that are used for prostate, for urethra, for rectal, and for bladder. The objectives, as Dr. Krauss mentioned, is to make sure that you're through certain limitations of your prostate, your PTV, V100, usually you want it to be greater than 95%. Ideally, you will be able to get it about 97, 98%, with V150 to be less than 40% and V200 anywhere between 9 to 12%. Urethra, you want to keep it under 130%. And urethra, the D10, you want it to be around 110, 114 to 116. Rectum, you want to make sure the V80 is less than 0.1 cc if you can. These are the two optimizations that I referred to as earlier, both HIPPO, this is one for HIPPO, and we've got one for IPSA. There is no wrong way or right way in using optimizations or which optimization to use, as long as you know what the constraints you put in and what your expectation is. Okay, I remember years and years ago, this is probably 20 years ago, when IPSA came out, it was inverse planning, and everybody thought, oh, now I don't need to put 16 or 18 catheters. Would I get a great implant with 4 needles, with 6 needles? That is not the case. Physics, you can bend the laws of physics, you can't break it. So you still need to be able to do your coverage and give a good optimization. And this is sort of what we were talking earlier, and Dr. Krauss brought another similar DVH out there. The great thing about the software is that you do have these stoplights, as I would call it. And these stoplights, once you run your optimization, is going to allow you to, you see it all green here, but if you see a red light or a green or a yellow light, you would know that there is some problems with the DVH that you have with the volume coverage, or you might have been over certain for your organs at risk, and you'll be able to manipulate it as you're going along. So if your number of needles are correct and appropriate and your contours are correct, you can do an optimization basically within a 10-minute time period. So a process for your ultrasound-based HDR for an experienced team could be anywhere from 90 minutes to 2 hours, as opposed to the 4 to 6 hours that you have for the CT-based ultrasound. Finally, you need to make sure about the connectivity. Once the connectivity and delivery, once the plans are complete and the physician is happy with the plan that you have generated, you need to make sure a second physicist or an individual trained person is reviewing your plan. Physician needs to finalize the treatment planning. And then you need to also make sure that all the QAs are correct with your indexer length. It's very important to make sure. There are 3 different lengths of needles, plastic needles that, for example, Elekta provides. You need to make sure which needles you're using and that you have confirmed the indexer length using a source position simulator. Now, whether you have a V3 digital or whether you have a Flexitron, they have different SPSs. So you need to make sure that you have used the correct one. Finally, survey is a must. We do recommend that you survey the patient prior to the procedure, so you have a baseline, and you need to survey the patient after the procedure, and once the delivery is complete. With that, I'm going to stop so that Dr. Gerard would have, Dr. Morton would have time to start his presentation. I can be reached at mmckee@wakehealth.edu. If there's any questions that you come up with afterwards or anything I can help with, I'll be more than happy to. Just contact me. I'm on ABS, AAPM, and Astro's directory. Thank you.
Thank you. Thanks, thanks, Mahta. Before we move on to my presentation, just maybe 2 questions that sort of come up a little bit. One is for both of you. Is there any limitation on the maximal basal dose rate or dwell time in your optimization?
Yes, the dwell time in general, regardless of whether it is CT-based or ultrasound, dwell time per dwell position is 999 seconds. So it's quite high. You will never get to that. So you're going to be having dwell times of probably 10, 12, 5 seconds per each dwell position. And again, depending on the number of needles, the volume, that could change. And the activity of your source, of course.
Okay, so thanks very much. So let me try to share once again, show how. Does that look okay, Mahta?
Yes, yes.
Perfect. Okay. So thanks everybody. Hopefully, you know, this will answer some of the questions that have been asked around, you know, using other imaging modalities. So what I would like to cover in the remaining time is maybe incorporating some other imaging and look at whether we should pay particular attention to contouring and identifying where the GTV or dominant intraprostatic lesion is when we're doing prostate HDR with ultrasound. We know that we've got lots of very nice tools for seeing the dominant lesion. This is an example patient. You can see where a lesion is quite evident. This is quite a small lesion, but it shows very nicely on T2 and diffusion weighted imaging MRI, as well as on a PSMA PET scan. So the question obviously is this something that is useful to incorporate into our planning? Should we and can we do this? We know that for patients treated with external beam radiation, this is data from the very well-known FLAME randomized clinical trial, giving a boost to the dominant lesion within the prostate is associated with a significant improvement in biochemical disease-free survival. Recall, all patients had 77 gray to the prostate, and those in the experimental arm had a boost given just to the dominant lesion to a total dose of 95 gray with external beam. And you can see that there was a significant improvement in biochemical disease-free survival, however, with no increase in toxicity. So the question obviously is this something we should consider for prostate HDR as well? So what I'd like to do over the next little time is to have us look at the value perhaps and benefit of incorporating GTV information into our HDR planning, and maybe briefly describe a way of doing so. Why? Well, because we can do it, okay? And we can actually do this much more easily with HDR brachytherapy than with any other form of radiation. It's easier to do even than with LDR brachytherapy. It's much easier to do than with SBRT, where we've got a lot of motion to account for. It enables dose escalation to the GTV with often a decrease in dose to the rest of the prostate. This would be focal boosting. I find it useful too, not necessarily for boosting, but just to make sure that we've actually got good coverage of the GTV, especially when the GTV is located in some more challenging situations. And I'll show some examples in a moment. And finally, and this is not something I'm going to dwell on this evening, is obviously if we're going to be moving towards focal HDR treatment. The technique we use in Sunnybrook as standard is very similar to what Dr. Krauss would use. We use general anesthetic, TRUS guided, everything is done without moving the patient. TRUS probe remains in place for the duration, including during treatment. Our average time is between 60 and 90 minutes. Probably the average would be 90, but certainly if the hammer is down, we can often get this done in 60 minutes. The setup looks very similar to what Dr. Krauss would do. And the patient is positioned, as you can see. Ultrasound probe is inserted. We use a very old-fashioned template, which we've had for over 20 years, as well as a very old, slightly rusty stepper. This is Dr. Hello hard at work, starting by inserting the anterior rows of catheters into the prostate. We use a very standardized template. So 90% of our patients would be implanted using this template of 16 catheters, starting anteriorly, working backwards. And what we find is 12 of these 16 catheters are around the periphery, and 4 are located more centrally. And the 4 central catheters primarily deliver dose to the apex and to the base. But this sort of arrangement seems to work well. These are just images taken through the procedure, starting anteriorly with the anterior rows, working backwards. As you can see, this would be our 3rd row and final row, as you can see. Length of time to insert these, it depends on the experience of the operator, but often this can be done in a matter of 10 to 15 minutes. And this sort of distribution, distribution of catheters usually gives quite a nice dose distribution, as you can see. I think we tend to have slightly hotter implants than Dr. Krauss does at William Beaumont. Our goal usually is to cover the whole prostate, as you see, with the 100% isodose, keeping the 120% usually in the peripheral zone. 150% is usually quite tight around the catheters, and usually the 200% are discrete and non-coalescing, as you can see. We don't always do this. In some situations, we might want to change our standard distribution. We've mentioned one obvious reason is if there's dose outside the prostate, if we're dealing with T3A, T3B disease. Dr. Krauss has already mentioned implanting seminal vesicles, if we're doing focal boosting or focal treatment for some reason. And also in some particular anatomic situations where a little more attention to the location of the disease seems to be of benefit. This is very similar to what Dr. Krauss showed. This is a patient with seminal vesicle invasion. Treating this with HDR is a piece of cake. All you got to do is advance the posterior row or posterior rows into the seminal vesicle, and you can get very nice coverage. You can see here seminal vesicle invasion on T2, on the diffusion weighted images, and on the ultrasound. And we can usually cover these very simply just by advancing the posterior rows of catheters. Extraprostatic extension, especially anteriorly, can sometimes be more of a challenge. And this is really where MRI is valuable. This is a patient, for example, PSA was 12, but a normal feeling prostate because the peripheral zone is entirely normal on digital rectal and also on examination. The lesion, you can see, is anteriorly on T2 and DWI with anterior extension beyond the capsule. Standard 16 catheters may be challenging because in order to push dose here, we're going to have to increase dwell times in these catheters that are quite close to urethra. So it's going to be difficult to achieve this. So the easy thing to do is to add in some extra catheters where we need implanting the extra prostatic disease. And just looking at our fusion image here with the GTV outlined, we can quite easily cover the GTV with these extra catheters and paying attention to the GTV in our optimization to ensure that the coverage is good. So the prescription dose was 15 gray, with the entire GTV is covered, and the D90 to the GTV would be higher than that of the rest of the prostate. Another application would be for focal boosting. So again, here's a T2 and a PSMA PET scan showing a Gleason 4+3 lesion in the peripheral zone on the right, as you can see. Covering this is going to be improved by placing some extra catheters right into the GTV. And this will allow us to get a very nice dose into the GTV. What you're looking at here is the 200% isodose. The prescription dose in this case is 19 gray, but 200% is deliberately concentrated in the area of gross disease. I'm lying, the prescription dose here was 19 gray. This is a patient who was treated with monotherapy. But you can see the dose to the dominant lesion can be significantly escalated without an increase in dose to the rest of the prostate. And if anything, the dose to the rest of the prostate seems to be de-escalated, which is quite interesting because when we looked at our results, looking at whether or not we should boost the GTV, the results were a little surprising. This is results from 2 prospective randomized trials we've had looking at 19 gray without a boost. This is looking at the biochemical failure cumulative incidence, or 19 gray with a boost. And in fact, there was absolutely no difference in rate of recurrence despite boosting with single fraction 19 gray. And what was a little perplexing to us at the time was that delivering a boost actually resulted in a decrease of late urinary toxicity. So even though our expectation was that patients who had focal boosting would be at increased risk of toxicity, the reverse seems to be the case. And I think our explanation is that focusing the dose and pushing the higher dose area to a particular part of the prostate where the cancer is will in turn decrease the dose to the remainder. It can also obviously be used for focal treatment, which we're not going to dwell on further at the moment, but the same process is going to be required. We always like to show nice implants. I'm going to show you a bad implant with our standard technique. And it's bad because there's some underdosing of the base. This is largely due to the catheters not being advanced far enough superiorly. But 2 areas that can be at risk of underdosage would be anteriorly, because of proximity to urethra, or at the apex, because perhaps these posterior rows may not be, maybe a little bit too far outside, and the algorithm is trying to balance rectal dose. Look at this patient. Another challenge can sometimes be anterior periurethral disease, where again there's a young man, 56-year-old, who has a very anterior lesion wrapping very close to urethra. Again, this can be challenging if we just use our standard distribution of catheters. Putting some extra catheters around where the disease is really going to assist us in getting good coverage. And this, again, will help us ensure that we've got good coverage of the GTV. Final area to look on, and Dr. Krauss did mention this, was disease at the apex. As a 59-year-old man we treated recently, you can see quite clearly on the T2 MRI, a large nodule at the apex of the gland. Here it is on an axial slice, quite close to urethra. So sometimes treating this is going to be a little bit of a challenge because we've got urethra, we've got a rectum, it's quite close to both. So first of all, modifying our standard template is very helpful. So some extra catheters, perhaps a little bit more centrally placed. The alternative, of course, would be to have one central catheter, as Dr. Krauss had mentioned. And this will enable us to get better coverage of the GTV at the level of the apex. So here's our dose distribution that we obtain. Even if we're not going to escalate dose, the blue, I think, is the 120%. You can see it's very nicely covered on the axial as well as on the sagittal images. Again, ensuring that we've got full coverage of the GTV. So that's sort of the situations when often we would consider incorporating GTV using MR information into our planning process. But how do we do it? Well, there are a few ways of doing this. The simplest way and least techie way would be so-called cognitive co-registration, where we look at the MRI, we look at the ultrasound, say, oh yeah, there's the lesion, which we can see on the ultrasound and contour on the ultrasound with cognitive information that we've obtained from looking at the MRI process. The first step, other options would be to do a rigid co-registration of the MRI and ultrasound, or a deformable registration, because remember the prostate shape is going to be different during the procedure. There's a rectal probe in place which can cause some deformation. So using a deformation or a deformable co-registration may have some advantages. What we do is we start by contouring on the MRI. So we take the multiparametric MRI, here's the T2, DWI, dynamic, contrast enhanced images, and outline our GTV on the axial images. There are commercially available solutions for this. This is one from MIM, where this patient in particular, this particular patient had actually two dominant lesions that were contoured. You can see on MRI and on the corresponding ultrasound. So it's able to do a deformable co-registration. Instead of using commercial systems, we've actually for many years been using an in-house system, which we call MR to ultrasound software. And this performs a deformable registration between the MRI and the TRUS, which we perform after catheter placement. Details are in the reference publication here, but basically this does an initial rigid registration, and then there's a scaling on each axial slice and applies the same deformation algorithm to the DIL on these slices. The results of using the software solution seem to be very similar to those of cognitive co-registration. This is again a paper that you can look up, but there was great similarity between the deformed solution and that of the cognitive fusion of 5 experienced radiation oncologists. The big difference is the length of time it took. We were able to do a co-registration on average in 11 seconds. So a very fast process. How this works is the MRI and the TRUS images, as well as the DICOM contoured structures, are loaded into our software package. We mentioned that there's an initial rigid registration and then a transformation. Once this happens, the fused DICOM RT structures are exported back to uncentral prostate. And this is a screenshot of what we see when we're actually doing the process. To give you an idea of the workflow when we are doing this, offline, we do the contouring as we've already mentioned. And these contours are then preloaded into our software process package. Patient comes into the brachytherapy suite and we insert the catheters, paying particular attention to where the extra catheters might be required in order to cover this. So the prostate is contoured on ultrasound. These contours are then exported to our engine, and in 11 seconds, on average, will provide us a fusion of the MR and ultrasound with an expansion of a few millimeters if we so desire. Some smoothing and post-processing occurs to carve the expanded DIL away from the urethra and to stop it expanding outside the prostate if we so desire. So this is then exported back to the Oncentra prostate planning system, which is what we use, and then planning proceeds with some extra dose constraints for the GTV. This probably adds about 5 minutes to the workflow. So just to sum up, we find that the standard 16 catheter distribution works really well most of the time. In some situations, for example, if we want to make sure we're treating an area that may be at risk close to the urethra, anteriorly, maybe at the apex. Some extra attention using MR-CT fusion seems, or MR ultrasound fusion seems to be beneficial. And it may also have a role for GTV boosting, which we use for situations where we're treating with monotherapy and also in the salvage setting. And this is something we find relatively easy to incorporate into our workflow. So thank you, everybody, and apologies for going a little over time. I guess at this point we can, I'm just going to stop screen sharing, and maybe we can look at some of the some questions.
Been trying to answer as many as I can in real time here. Some of them are hard to do just in a little chat box like this. You know, I'll comment briefly. You know, I had some questions about, you know, the numbers of needles. You know, one question about, you know, acute retention with increased needle numbers. It's hard for me to say if I've personally had any experience with that directly, because I sort of always do them the same way, so I don't have a comparison. But what I can tell you is that if you select your patients well, it's pretty rare for the patients to need to go home with a catheter, to have to put a catheter back in. You know, if that happens, it's usually in a patient with very aggressive disease that I'm stretching the indications of brachy because I think they'll really benefit from it clinically. And they're probably not the most well-selected brachy patient. Gerard, I don't know if you...
Yeah, you know, we published a paper on this in the Green Journal last year, looking at acute retention in over 500 patients. So the overall acute retention rate. So normally we take the just to let you know, we take the catheter out before waking the patient. So the patient wakes up, no catheter in place after the procedure is done. He goes home, typically 1 to 2 hours later, without a catheter or without any alpha blockers. So the acute retention rate overall is 5%. So it's pretty low. There were a couple of risk factors for retention. Patients on pre-existing alpha blockers seem to be at increased risk, and patients who were on androgen deprivation therapy were also at increased risk of retention. But remember, overall, the risk is quite small.
Yeah, I'll just say, we prophylactically put everyone on alpha blockers immediately after the procedure and wean them from there. But trying to see if there are any questions that we couldn't. Some questions about bladder dosimetry. That's one of the fundamental differences between CT planning and ultrasound planning, is you really can't get good bladder dosimetry. There's not much to contour. I didn't really mention this. I did mention it in the chat box. Make sure you fill the bladder before you acquire your images. That'll serve 2 purposes. We'll usually fill it before acquisition with about 150 cc's of sterile water, clamp the catheter, and we won't unclamp it till after treatment is done. 2 purposes: 1, it'll make visualization of the base easier, and 2, it will also decrease bladder dose by pushing more mucosa further away from the radiation. So
I think there was also one question regarding whether one uses general anesthesia or spinal. Majority of our cases are all general.
So you know, with CT-based planning, because when we started our program, we were using CT planning, and I found a spinal anesthetic worked very nicely for CT planning. And the reason is it took so long, and often we were doing some manipulation because of catheter displacement before the patient came for treatment. So having some spinal analgesia still on board was a big advantage. For ultrasound-based planning, everything is done pretty quickly. The ultrasound probe is in place, and we've done some under spinal. Certainly it can be done, not a problem. Recovery, though, is longer because it does take longer for the spinal to wear off. So our preference would be to do a general in that situation.
So, hi, Hiram. I see your question there. How many in a day? it sort of depends on your infrastructure and your setup. If, Gerard and I are spoiled in that we've got the shielded OR. If you have the shielded operating room, you never have to move the patient. If I was in private practice with this type of a setup, 3 in a day, I think would be very feasible, maybe even more if you're really motivated. But with the way we're set up at Beaumont, we never do more than 2. Obviously, we're every case we do is a teaching case. I've always got a resident with me, so we're not racing through them. Our anesthesia time here is typically in the range of about between 2 and 2.5 hours, but a lot of that is teaching time.
I mean, I think it depends on where you're at, Hiram, and where, the experience. Because remember, it's not the radiation oncologist; it's a team approach. Okay, and so it really has to do with having a team. We're very lucky. I'm sure Dan is the same. We're very lucky in Sunnybrook that we've got a very engaged team. They're all very experienced, and we've got a very slick process. So we do LDR as well. I didn't even mention LDR implants for certain patients. So pre-COVID, we were doing 5 cases in a day, which would be a combination of maybe typically 3 HDRs, 2 LDRs. It's easy enough to do. If we're just doing HDR, getting 4 done in a day is usually fairly simple. More than that is a bit of a stretch.
And we do 3 LDRs in a day and potentially 1 HDR with 1 LDR or 2 HDRs in one day.
Yeah, so we could do 4 HDRs in a day. But again, it really depends on your situation. And when you start, I think most people would start with 1 a day, just to take it easy, make sure the process works, and gradually build up. Certainly 2 a day, 3 a day would be, I think, within most centers'
I would agree.
Expectations.
Yeah.
So questions about spacers. I'll comment on those. First off, we don't usually use them. If you're going to use them for HDR dosing and you're planning your case on ultrasound, first of all, you're going to have to be really, really careful not to get any air in the syringe, because it will just foul up your imaging, beyond recognition. But I'll say this, we don't do it for HDR monotherapy for the simple reason that patients don't get rectal toxicity. I mean, this is one of the reasons that I love this treatment so much, is because you essentially remove one of the 2 major toxicity profiles from prostate treatment. In boost patients, I usually don't, for the simple reason that these tend to be patients with aggressive disease, high risk for extraprostatic extension. I'm a little bit more conservative maybe than some other people in terms of who I offer it to. I get very leery if there's a risk of extraprostatic disease. I mean, the idea of injecting spacer into a space that's involved by cancer freaks me out a little bit. So just by natural selection, I usually don't do it for HDR cases, even in the boost setting, unless I have a clear anterior lesion with nothing coming close to the space you're injecting. Gerard?
There's no role whatsoever for spacer in brachytherapy.
Yeah.
Certainly,
what about an LDR?
No.
Yeah.
I mean, the reason I'm saying that, I know I said that really, really flippantly, but if we look at HDR in particular, we've tracked this very carefully. We've got prospective quality of life data. There is pretty much 0 rectal toxicity for HDR monotherapy. Now, you may make a case for when we're using a boost with external beam, but I think the easier way to minimize that is to reduce our PTV for the external beam portion. But we really have very little rectal toxicity. So I don't think there's a problem there that we need to solve. Having said that, there are some reports looking at the use of spacer with brachytherapy, showing a reduction in grade 1 toxicity, which isn't really all that impressive, especially as these are non-randomized, non-blinded studies, and there has to be a placebo effect. But so I'm not a fan of spacer, but that's probably just my Canadian perspective, my Canadian parsimony, where we don't like spending money unnecessarily.
There's a question about spacer for salvage cases. Interestingly, I did that one time, and it was in a patient who had external beam and actually had, just sort of a mild smoldering radiation proctitis to begin with. So I did it for that single case. We were very careful about not getting air into the system, and it actually worked out pretty well. But I was a little nervous about what it was going to do to the imaging. But as long as you keep air out, I think you're okay. But I wouldn't have done it if that patient didn't already have some radiation proctitis to begin with.
There's a question about whether anybody uses fiducials.
Multi-fraction cases. You set up the we've always, we don't put the probe back in to verify needle position for subsequent fractions. We do an X-ray and verify the needle depths relative to the fiducials.
I mean, it can be an opportunity if you're using fiducials for external beam treatment.
Right.
So if you're doing HDR, first of all, and you are concerned about margins and you want to be tight, obviously having fiducials in may have some advantages in that situation.
Okay.
So Dan, what is too significant a TURP defect when you would not implant a patient?
Remember, external beam is still a really good treatment for prostate cancer. So, unless, as much as I endorse HDR and as much as, and in all things equal situation, I favor HDR. If they've had a prior TURP and they've got, run-of-the-mill Gleason 7 disease where you'd expect an excellent outcome with any treatment approach, I will steer them to external beam. If it's someone that you really think is going to benefit from brachytherapy, or it's someone who is really motivated to get brachytherapy, what I'll do is we'll do a volume study. I'll put them in lithotomy, ultrasound them, and look at the defect. And it's not just the size, it's sort of the configuration and position of it. What does the base look like? Is it really irregular? How confident are you that you can cover the disease? I would take it on a case-by-case basis. I can't say that I have any type of measurable criterion for who I would treat and wouldn't treat with a TURP. Gerard, you?
It's difficult to give a definitive answer to that question, I think, because how big is too big? I don't know. I think I'd look at the time and how long it is since they've had their TURP, like a small defect, whatever that is. But I agree with Dan. In general, if there's, if I see a significant defect there, these are patients that do tend to steer towards SBRT rather than brachytherapy. Although having said that, it is easier, I think, to cover patients who've had a previous TURP with HDR than with LDR.
I don't quote any difference in sexual function preservation. A higher percentage of boost patients are going to get hormones also, so that's going to sort of muck that assessment up as well. If you look in our database, our brachy patients tend to have slightly better sexual function preservation than our external beam, but they're also younger and healthier. So I tend not to draw, a real great distinction in that regard.
I think it's difficult to know exactly what the etiology is of sexual dysfunction after brachy. Like, what is the target? And I know we've, just from some of the questions you're asking about the penile bulb dose, and that probably is not as relevant. I think, when we're trying to tease it out in our database, it seems as if the only factor that seems to, the only dosimetric factor we found that's of significance, in fact, is the V100. So high V100 or a higher D90 seems to be associated with increased risk of erectile dysfunction. So I think we're probably really affecting the nerves that are very close to the prostate and close to the capsule, rather than dose delivered to the penile bulb.
The median lobe question, I think you have to look at where the disease is and how big is the median lobe, how much extra bladder dose are you going to be giving. patient's got a lot of disease up at the base, and it's aggressive disease, and it's a big median lobe that's going to be difficult to implant. Maybe brachy isn't the best option. But if it's if the patient just has a small volume of apical disease, I usually won't chase it.
Okay. I'm thinking we are now 23 minutes over time. I would think we should probably draw this session to a close. I would like to thank all of you for attending and all your great questions. It was really nice to have such interaction. And all the questions, I think, are, really show that there's a lot of thought behind these, and these are very real questions that are being asked, addressing real issues and situations. I'd also like to thank my two co-panelists, Mahta and Dan, for their fantastic presentations and their time and commitment to this. And also, of course, to the ABS for allowing us this opportunity to broadcast. So this is going to be available, and there is a link on the chat, I think, to this presentation, which is going to be made available, I think, Melissa, on the ABS website. Remember, this is a SAM, and there's also a link in the chat to the SAM form, which you can complete and claim credits.
Don't forget the ABS 2021.
Don't forget the ABS 2021.
Exactly.
So thank you, everybody.
Thank you.
Stay safe and stay well.
Thanks. Bye-bye.
Bye.